I have something to offer. Alright, so I'm not going to teach, I'm just going to talk and share the journey of discovering India's first manual therapy concept, which is KKMT, also known as Krishna's kinetic manual therapy. So basically, if I talk about KKMT, here what we do, we actually focus on the orthokinetics as well as we focus on the homeostatic forces. You see, if my joint is in place, it's not just because of its structure, but also because of the forces that keep it in the place, right? So even if I move it around, it comes back to the socket. And there are a lot of things responsible for that. There are muscles, there are ligaments, the capsule, all this. So what we did, we realized that why don't we work with the forces to ensure that our joint mobility is regained, our orthokinematics is regained. We are not going to technicalities because I told that I'm not going to teach you, so don't worry about that. Basically know that this is functional. We focus a lot on orthokinematics and we focus on homeostatic kinetic force. Alright, the formatting is a bit hazy here because of the change in the laptop. But basically what we did, the journey started in 2004 when I was still studying, and we realized that there were some potholes in manual therapy at that time. For example, most of the techniques were focused on biological approach rather than the biopsychosocial approach. So we thought that this is a huge gap. It's an elephant in the front room that needs to be addressed. So we felt that gap. Then we felt that most of the techniques were talking about pain as an input from the periphery. But if you look at these people, they are fighting, they might not be even feeling pain at that time, right? Okay, how many of you have fought? As a kid, how many of you have self-development फोड़ा है? मैंने फोड़ा है ना? अब सबसे बढ़िया मतलब diagnosis करनी है कि सर फूट गया अपना ही अब बचा हुआ है. If it is painful, then it is you will simply get along. But अगर फट जाता है तो दर्द नहीं होता. कितनों को मालूम है? मालूम है ना? It means it's not exactly the input from the periphery, right? Pain is a complex phenomena, and we cannot just say that okay, if there is pain, it means there is damage, all right? So we felt that this was a gap. Then most of the techniques were either one-dimensional or two-dimensional. In functional life, we never performed this kind of motion, right? We have all these three-dimensional, 3D motions, so we felt that was one of the potholes. Then we realized we have been using a lot of nosodic terminologies, like when we see a patient, we say, okay, you got slip disc. Now if the patient hears slip disc, the patient will feel that there is something that has slipped in my back, and if I move, that's going to fall apart. So what happens? The patient starts getting kinesophobia, right? He starts catastrophizing all these things. And nowadays, even in exercises, we don't even use such terms, right? And you'll see if someone is using that term, just a quick demonstration, I'll try to wrap up quite fast. Can I get just one person? Irrespective of back pain or back pain, just stop. I just want to demonstrate something, how to get rid of such catastrophobia or such kinesophobia. So what we do, as I said that most of the patients think I have slip disc and they'll stop moving their back. No matter how much you convince them, that thing somehow doesn't go out of their mind. So what we do, we'll ask the patient to stand. What we have to do, we have to make sure that the mobility is regained. The person's thought process changes. And how will you change it? By stopping the person to think about that catastrophe. So what I do, आप यहाँ पे usually patient होता है ज़्यादा घूमने का कोई भी एक्सरसाइज बताओ तो बहुत ही बचा करेगा because patient thinks that there is slip disc, something is going to slip. आपको क्या करना है? मैं माइक आपको टच करने की कोशिश करूँगा. आपको खटना है, आपको हिलना नहीं है, ना बॉडी को मूव करना है ताकि माइक आपसे टच ना हो सके. ठीक? So this is how you get rid of kinesophobia. Thank you. So what you did, you distracted the client from that and you simply gamified it. So we felt that there was this issue of nosodic terminology, as Hippocrates is do no harm, right? Then the kinesophobia, I mean, you just simulated the amygdala and the patient is all frightened. We thought that was another pothole. And the posture. Sometimes we overdiagnose few things, right? I'm not saying posture posture is not important. I'm not saying that posture is not correlated with back pain, but we also need to understand that correlation doesn't mean causation, right? It might be a cause, but not necessarily. So we need to stop diagnosing. You see how many types of sitting position we have when we were the kids, right? Another thing was asymmetry. Asymmetry is not necessarily a cause of pain. It may be, but it's not all the time. Like you see, Usain Bolt, who is the fastest runner, if you look at his right leg is half inch shorter than the left leg. So what are you going to do? Are you going to fix it? No, he's getting advantage of that. He's getting more flight time. Before he lands, he has an extra space. So he utilizes it. So we need to stop over-diagnosing asymmetry and posture, etc. Then we felt that was poor joint mobility assessment, because most of the time, few joints you assess, they have mobility in millimeters. So it's actually not possible for you to evaluate that. Then there's qualitative evaluation by Enfield, and it varies a lot. There's very poor inter-rater and intra-rater reliability. So these were the potholes. So we started filling them. What we did, we realized that let's focus on orthokinetic motion and joint forces. And with that, we can improve the osteokinematics. Alright, so we work on orthokinematics and the joint forces. Now, how KKMT is different? First, we use biosocial approach. Then we use functional 3D osteokinematics and orthokinematics. We use a lot of muscle memory techniques and neuroplasticity concepts. We use progressive habituation, and we avoid claustrophobia. And we don't treat body as made up of block that it has to be symmetrical all the time. Alright? So we have different techniques in there. We have joint gapping, motion facilitation. We started rolling facilitation. All the time we had heard about gliding, right? But there's also rolling component. How do you facilitate that one? Because there's always gliding and rolling happening together, right? There's no pure gliding response. And then there are different types of glides that we develop. And the other thing is that we have entire different protocol. KKMT is not set of techniques. It's a protocol where you have the entire assessment. You have assessment, then you use different techniques to heal the patient, and you go on. Now, after that, we started disseminating. As I said, we are going to start talking about the journal. So in 2015, these were my first two students in Cameroon who were taught KKMT. Then we launched the first batch of KKMT in Cameroon, in West Africa, in 2016. In 2016, we launched it in Sri Lanka, in University of Philadelphia. Then in 2016, one of my team members, Dr. Chakshu, she's also the co-developer, she introduced it in Singapore. Then in 2017 is when we launched the first batch in India. After that, 2018, we launched it in Malaysia, 2019 Ukraine, then 2020 Qatar, 2021 we introduced in Uganda, as well as to the Uganda's national cricket team, which is of course a part of International Cricket Council. We introduced there also. And then we started our first center of KKMT in Cameroon, which is still functional. And then in 2023, we launched it in Georgia. We were also featured on PhysioCon. And so far, we have written multiple books on KKMT. So, the slide is not moving. All right. Apart from that, we have various theses which are published, and the researchers are also indexed in WHO's clinical trial registry, Cochrane Library, in ICMR site, and so far the milestones I can talk about is that we are the first complete school of thought in manual therapy which is developed by an Indian, and KKMT is the first technique by an Indian which is included in the national curriculum of physiotherapy in Cameroon, which is developed by Ministry of Higher Education, Ministry of Public Health. Apart from that, we are the only technique developed in India which is taught offline in 9 countries, and online we have taught to the students from 110 countries, and it has been proven efficient in many RCTs. But of course, at Newton quoted, in Latin, nano gigantum, humerus incidentus, means it's just by standing on the shoulders of the giants that you can see far. So it's not like we got it out of the blue. That's why we call it development and not invention, because it was based on all the findings and all the inputs by all the schools of thoughts in manual therapy that was developed so far. And at the end, before I reach the end, I would like to, I must appreciate the effort of my guru who is present in here, Dr. Ashok Shukla. Let's go outside. Okay, alright, so he was present there, I just wanted to acknowledge it. Finally, I said I was here to talk about something and I had to offer something. So since we are still with the basic aim of science is keep asking questions, right? That's why even in the hypothesis, we never accept the hypothesis. We either reject it or we fail to reject it, right? So to move an extra bit, we are inviting PhD sponsorship. We'll be sponsoring 30% fee of your PhD. And if you want to apply, please, you can scan the code and you can fill the form. We are looking for people who want to do PhD KKMT so that we can further improve it rather than just sitting in the corner in our own bubble that we are the best. So we want to challenge it, we want to keep improving it, and that's what I have to offer. Thank you so much.